Flexion and extension. Okay? So, some of the landmarks are going to be similar. Go ahead and lay on your back. Okay. Now, some patients will be uncomfortable laying flat on their back, and so sometimes you can bend the other leg up, which is fine, as long as you're watching for substitutions. When you're doing hip range of motion, I would discourage this, but you could do like a little towel roll, just a little if you needed to, if they were really uncomfortable. And I'd recommend that you try to modify and keep them in the standard position and make little modifications before you switch them all the way out of the standard position. Okay, so we are going to take off Marlene's shoe because this one in particular, there's a lot of heel drag, and we don't want to have her having to overcome the resistance of the rubber on the shoe, right? So my landmarks are going to be greater trochanter. You guys remember how to find that? Mm-hmm. Lateral joint line. So the specific landmark, I believe, should I say the right thing? It's going to be the lateral epicondyle again. Know how to find that, right? Okay. And then the distal landmark is going to be midline of the tibia. And you're going to use the lateral malleolus, which is part of the fibula, as your distal or your movable landmark. Okay? You want to be down at eye level with your goniometer. Okay, so lateral epicondyle, and make sure that you're not palpating the tibial plateau. Okay, because they both are prominent. And so you're trying to get right at the knee joint line. So your patella is a decent landmark, but sometimes people have a patella that is elevated or depressed, and so the patella isn't the best landmark for the midline of the knee. So you got to find your condyle, and you got to come at it from the superior part, not the inferior part, because you're going to end up either on the fibular head or the tibial plateau, I guarantee it. So come from this direction and hit the landmark from there. All right, so then you just have your patient bend the knee up. Okay, just bend your knee as far as you can. And you're going to recheck your landmarks. Okay. Can you go any further? Okay. And then she's wishing it up there. She's got a lot of knee flexion. Okay. And if I wanted to actively assist, I could actually push it a little bit further. Right?
Yeah, I feel like there'd be a little bit more.
So she's right at 150 degrees there. And then coming down, you're going to be working with patients that have had total knee replacements. You can do a lot of knee range of motion. Your goal is to get them to 120, even though 150 is normal. 120 is what you need to go sit to stand with a normal sit to stand form, right? Extension is the other big guy that you work on with a lot of your knee patients, ACL repairs, knee replacements, etc. And so they'll come in and they'll be kind of in this flexed position, and you try to get them to straighten their knee out, and they can't. So let's just say that she's a total knee replacement patient with a total knee replacement, and she comes in and she's about here, and I can't get her any further down. Okay, so her resting position is at 14 degrees of flexion, and then she bends up and she goes, you know, maybe to like 82. Okay, so what I would document there is right knee flexion, active range of motion, 14 to 82 degrees. Okay, and then for extension, you know, let's say she was at like 16 and I was able to get her to 14, you know, then her extension would be lax 14 degrees or 16 degrees to neutral. Okay. It's a little more complicated than that, though. Some patients have hyperextension. So the best way to really look at full knee extension is to put the ankle on a towel. And some patients will have so much hyperextension that that won't even be enough, that you have to use 2 towels. I think with Marlene it'd be good. Now straighten your knee out as far as you can. Okay? Did you see that extension happen there? Now if I put her here, just relax. Relax. Okay, now straighten your knee out. I might not get, if there was some hyperextension, I might not be able to see that because she's running into the table. See what I'm saying? So you really should put them up on a towel.
Could you use a bolster instead of a towel?
A what?
A bolster.
You definitely can use a bolster, and I probably would have used one, but I just grab whatever I see first. But a bolster works very well. Okay, so we're going to prop her up, toes straight up towards the ceiling, and same landmarks: lateral epicondyle femur, greater trochanter, lateral malleolus, and then what I want you to do, Marlene, is just push your knee down as far as you can. And she is right there at 1 degree past 0. So she's right knee active range of motion extension, 0 to 1. Normal is 0. There's discussion or I don't know, surgeons, etc., orthopedic people that say 10 degrees of hyperextension is considered normal and that there should be some hyperextension in the knee. But I think 0 is functionally significant. It's what you need to be able to do everything you need to do. And I think hyperextension sometimes can be damaging. So if we wanted to do that passively, the way that I would do it usually in the clinic is just grab proximal tibia and distal femur, and I'm going to apply pressure downward and try to get more extension. So with her, I can probably get her, if you just want to watch. She actively could go to 0. Straighten your toes up. She went to 1, so push down as far as you can.
Oh, me?
Yeah, and then if I wanted to try to get a little more, I could try to push her into a little more extension, which I can get a couple more degrees there, right? So in the clinic, you know, Dr. So-and-so wants the patient to get to 0 degrees, you know, by this week. And so a lot of times you are pushing, measuring, and talking to your patient and saying, let's try to get 2 more degrees, you know, and so it's kind of an interactive goniometric thing. Same thing with flexion. Okay?